Hi, everyone. My name is Ryan Panchadsaram. I'm from COVID Exit Strategy, and I just want to welcome everyone today. It's October 14th, and for folks who have been joining us since the beginning, these calls started out as a call and have turned into this Zoom where we bring together groups of folks that are working towards helping out on the COVID response. Most of our groups are nonpartisan. We all are working toward the same intent, which is to get us back to normal, the new normal, whatever that ends up looking like and being. And so this conference is being put on by us at COVID Exit Strategy, our friends at United States of Care, the Duke-Margolis Health Policy Center, Resolve to Save Lives, and the U.S. Digital Response. I'm going to have each of my colleagues here introduce themselves and give you a quick peek of what they're going to be talking about today. So we're going to spend the first 30 minutes running through things, and then we'll have 30 more minutes for questions. Marta?
Good morning. My name is Marta Boshinska, and I'm consulting professor and deputy director for policy at the Duke-Margolis Center for Health Policy at Duke University. I will give an overview, state of the states, on how we are doing with COVID spread, and also we'll briefly discuss some of the work that we just released this morning together with Rockefeller Foundation on testing protocols for schools K through 12.
Wonderful. Cyrus?
Good morning. Cyrus Shapar here. I'm Chief Science Officer of the COVID-19 response at Resolve to Save Lives, and I'll be talking about COVID-19 in our presidential election.
Andrew from US of Care?
Andrew Schwab from United States of Care. I'm Director of Policy, Federal Affairs, and Partnerships, and I'll be talking about the situation on Capitol Hill with Congress in terms of COVID pandemic response.
Thanks, Andrew. Raylene?
Hi, everyone. I'm Raylene Young. I'm one of the co-founders and CEO of U.S. Digital Response. I'll be talking about the impact COVID-19 has had on the state and local level, and specifically covering healthcare, elections impact, and unemployment.
Thanks, Raylene. Robin?
Hi, I'm Robin Carnahan. I'm working with the U.S. Digital Response team as well, although I'm based at Georgetown University's Beck Center, used to be at 18F in the federal government, and also former Secretary of State, so know a little bit about elections.
Wonderful. Thank you, Robin. Marta, do you want to kick us off? I'll start sharing my screen.
Great, thank you. So last time we had this Zoom call, we were on September 22nd. And so what you see here on the left-hand side is actually web archives from September 22nd. And on the right-hand side, you see today's map on our website. So just wanted to point out a couple of things. I guess the two major differences, one is sort of more obvious than the other. The major difference is you're seeing far fewer yellow states. So Arizona has moved and Oregon into a different category, as did Ohio and Pennsylvania, Massachusetts, Connecticut. So there are changes over there. And I'll dive a little bit more into what is happening, but this is part of a larger trend of cases increasing throughout most of the country. What is a bit harder to see in this map, because our dark red is uncontrolled spread, is that in the Midwest, some of the darker colors that we had, if you could go right on the left-hand side and hover over some states like North Dakota and Montana, South Dakota, and then maybe Wisconsin. And then on the right-hand side, which is what is today, a comparison to these numbers, we are at much higher numbers for all of these. In fact, when you look at North Dakota, if you were to actually compare it in terms of cases per million, those are cases per million, it is higher than what we had in Arizona, actually, which was obviously a really high outbreak. They're actually also even higher than what was recorded in terms of cases with New York, but that was before we really had really good data and a lot of testing, so that's a hard one to compare. But North Dakota and Montana and South Dakota are really sort of hitting national records for the number of cases per million. So let's dive a little bit more deeply into what is happening. So Ryan, if you could switch to another screen that shows us the cases per million and also the percent change in the number of cases. Excellent. So on the left-hand side, you can see the number of cases per million. I think you can see in this map much more clearly where the cases are really high, and it has shifted again from the the Sun Belt towards the Midwest, and you can see this clearly. And if you could scroll by the number of new cases per million, the other direction, yes. You can see that, again, some of the Midwestern states are showing up here, and the numbers, as I mentioned, are really incredibly high. What you can also see here is the currently hospitalized. Those numbers are high and rising. If you look through actually the spark lines for currently hospitalized, and you look sort of what is happening in each state, we don't have a metric for the actually percent increase in these, but you can see that for a very small number of states do we actually see decreases. What we are really seeing is increases in hospitalizations. And this just goes along with what you see on the right-hand side, which is the percent increase in the number of cases that you see across the nation. Things are very much sort of in the mid-north part of the country. You do see a slowdown in some of the southern states. So they are still sort of in a reversal. What is interesting is, for example, what you see in Arizona. Arizona actually has had a pretty substantive increase in the number of cases, almost 50% increase in the number of cases in just 2 weeks alone. So they're up on an upswing. Also, what you can see is some of the states that have been doing very well are having pretty large increases. New Mexico is actually one of them. They've been managing things quite well, and they're almost having a doubling of cases. Some of the states in the northwest, actually, if you could go on the map there, northeast. Again, they're starting from a relatively low base. So Vermont and New Hampshire had a small number of cases. They still are doing quite well, but those are pretty dramatic increases. The same thing with Connecticut and Massachusetts. Connecticut was in the green category for a while in terms of how they were doing. Now they have almost 100 cases per million. So we definitely are seeing a large shift. This might be yet another wave that is the fall wave that everybody has been talking about. It is starting to show up in hospitalizations, so it will be really important as we go along. Ryan shortly is going to show some really interesting data from a symptom survey that also asks about masks, and you'll see that mask wearing will be really important, and it actually shows that it is important because there is actually a correlation between the between the disease spread and mask wearing percentage. So I'll pass this on to you, Ryan.
Thanks, Marta. Yeah, we just pulled into our site this great data that's coming from the CMU Delphi group. And so what they do, if folks aren't familiar, is they run a survey on Facebook that asks a large range of questions. And from it, they're able to give you this, for us, an earlier leading indicator of what's happening on the ground. In this case here, what we can see is in this new data set, they're asking how many folks are actually wearing masks in public most or all of the time, as well as another question of, do you know who in your community, do you know someone that has COVID-like symptoms? And it's a really fascinating data set because it starts to give you these previews of what's working, what's not, where are hotspots, where are they appearing. And so on our site, if you go to the section where how is this disease spreading, we've pulled in this great data. So you can sort by the community spread piece. You can also sort by the mask wearing piece. And so this data set, I think it's almost 70,000 people get asked it every day across the country. I think they've had over about 1.2 million survey respondents over the past month. It's a pretty impressive data set. The other change before handing it off to Cyrus, I wanted to kind of flag for folks is there's a new feature that we added, which lets you click into a state now to get a preview of what things have looked like from the beginning. And this map here adjusts depending, of course, on each state. So take a look at what the cases target is, and you can see positivity. We cap it out above 25% because at a time when there wasn't much testing, positivity rates were really high, but this is where you can see a lot of change in the different states. And so if you're digging into any of them, you can do it that way. And with that, I'm going to talk a little bit later about federal data issues, but first I'm going to hand the baton to Cyrus and let me pull this up.
Hi, so we're 20 days away from one of the most important presidential elections of our lifetime. And in that 20 days, about 1 million Americans will become infected with COVID-19 and 15 to 20,000 people will die of COVID. And just to give a sense of, how many people that is, that's the same as having a Hurricane Katrina hit the US every other day until the election. So it is a staggering amount of people who unfortunately will die, and also, in terms of infections. And COVID-19 remains the most disruptive public health event in over 100 years. But we can't let that disrupt our democratic process. I think we all recognize that people need to vote and they need to feel safe doing so. So it's essential that mitigation strategies are in place at polling locations, just as they are in schools, at the grocery store. And we really can't compromise on safety, just as we can't compromise on vaccine safety. We have to make sure that these locations are safe and that we're clearly communicating, that they are safe, especially to populations that might have a particular fear of in-person voting. And the media can play an important role in communicating that we can vote safely, even as the situation in the community might be worsening. So, CDC has guidance, which is what Ryan's showing here. I'll just talk about a little bit about that, but it's considerations for election polling locations and voters as well. And really covers, the principles about how these locations can be safe and some of the best practices while you're at a voting location. And there's options for voting, of course. We want to look at different options, making sure that there's accessible and secure mail-in ballots, but also safe in-person voting sites. So when we think about, it's not rocket science when you think about making safe polling a reality. It's just like a grocery store, as I said, or another location, things that we do every day. How do we engineer this particular event of voting to be safe? And you have to think about the risks of COVID related to the number of interactions you have, how long those interactions are, how close you are to other people. Is it indoor or outdoor? And are there personal behaviors that we can take on, like wearing masks, that can reduce risk? So all of those things applied to the setting of voting sites. How do we engineer it so that it's as safe as possible? And so some of the ways that the CDC document discusses are, well, first off, less people, right? We want less people to show up at voting locations in terms of being congested at the same time. So having options like advanced mail-in ballots, for example, can reduce the surge on voting sites. Also having other alternatives, drive-through in some places, to just in-person polling can help. Over time, in terms of less people, we could have longer voting hours, for instance. And if there are going to be lines, make sure that they're distanced so that there's less interaction between people waiting to vote. There should be line and crowd management. There should be one-way foot traffic so people aren't crossing each other, just as office settings have done in COVID times. Modified layouts, clear signage, those are all important. Less time at the polling location is important, so making sure it's an efficient process to get in and out. Reducing environmental risk, making sure that you have well-ventilated indoor areas or outdoor areas if possible, reduce touch points, cleaning and disinfecting these surfaces and equipment, and of course, reinforcing personal behaviors that we should be doing everywhere, not just in voting sites, but things like what we call the 3 Ws, wearing a mask, washing your hands, and watching your distance. All of those things, of course, will be important for voters and staff and poll workers when people are voting. And so it's essential that all these are in place, that people follow guidance. There is guidance out there, but we can do this safely if this guidance is followed. And it's a mix of both the election officials making sure that sites are safe and people have enough equipment, they're offering hand sanitizer, these types of things, there's clear signage, and then that people going to vote understand, they need to be vigilant about maintaining best practices to protect themselves from becoming infected. And now I'll turn it over to Christina to talk about K through 12 testing.
Thanks, Cyrus. Marta, is Christina here, or do you want to take that?
I'll take that. Thank you. So I just wanted to flag for you on this call that the Duke-Margolis Center, together with the Rockefeller Foundation and Johns Hopkins, released a new report or a new white paper on testing protocols for reducing COVID SARS transmission in K through 12 schools. Just to flag for you, this is also, so I am not able to speak to this. I just wanted to bring this up to your attention. If you have questions about it, you can reach out to either the Rockefeller Foundation or reach out to Patricia Green at duke.edu. So I recommend this highly. This is sort of first of a kind report in this space. So I just wanted to flag it for you. Just came out this morning.
Thank you, Marta. Andrew from US of Care.
I'm going to talk a little bit about what is and is not happening on Capitol Hill in terms of pandemic response. Both houses of Congress have yet to deal with a new round of aid to states, which is a critical problem that needs to be dealt with as historic revenue declines are happening in state capitals. And although these are better than originally forecasted, states are still in pretty poor shape, and with requirements to balance budgets at the state level, you'll start seeing cuts in state budgets to higher education, to Medicaid, to assistance to the disabled, to K through 12 education. Those are the places where states have traditionally gone first in bad economic times. US of Care has been advocating, along with the National Governors Association, for $500 billion in additional state aid, federal state aid, but that has not happened as of yet. The House, as everyone knows, has passed the HEROES Act several months ago. Republicans were unable to come around a consensus on a smaller $300 billion bill, and Secretary Mnuchin and Speaker Pelosi have not been able to come to terms either. And the interesting thing is that Republicans are now slightly distancing themselves from the president, who has been pushing for a bigger and bigger deal. The real big issue here is that these remaining things will have to be dealt with either now, after the election in lame duck, or sometime very early in 2021 in whatever administration is in power at that time. There's been major losses of healthcare coverage, which is not something that we would want to see during a pandemic, when the health of one person is more connected to the health of each other than ever before. We have been advocating at US of Care for some temporary fixes to bolster coverage. Many people will be eligible for Medicaid or the exchanges. Report from the Employee Benefits Research Institute came out yesterday that is more than 14 million Americans may have lost employer coverage, and that includes dependents. So temporary fixes are things that Congress can do, like a special enrollment period, COBRA subsidies, which have precedent from the 2009 stimulus, increased FMAP to try to get states not to cut from Medicaid. There was a 6.2% bump in the first round of COVID stimuli, and there has been advocacy for anywhere from repeating that 6% to all the way up to a 12% bump to try to get that going. The other big outlying issues that remain unresolved is money for contact tracing, testing, and isolation. US of Care since April has been advocating for $46 billion for contact tracing, and that has not yet happened. And we're seeing the effects of what happens when there isn't contact tracing with the White House outbreak, and local governments like in New Jersey, where there was an event that the president held that is not being able to be contact traced by local public health officials there, and that makes everything more difficult. I would also add that of note, yesterday at the Medicaid Health Plans of America conference, the just now previous chair of the National Governors Association, Republican Larry Hogan of Maryland, was pushing Medicaid plans to advocate to their respective members of Congress to increase FMAP funding, because states are just going to have no choice but to cut Medicaid if they don't get the state and local funding. So the big thing that I'd like to leave everybody with is that it is critical for Congress to act. These issues are not going away. As one of our previous speakers alluded to, this is the biggest public health crisis in 100 years. And money for states, contact tracing, isolation, quarantine, and a whole host of other economic issues is needed from Washington either now, which would be best, after the election during lame duck, or in early 2021.
Thanks, Andrew. Raylene and Robin from the U.S. Digital Response, let me pull up your slides if you hop on video.
Hi. So at U.S. Digital Response, we're actually a team of nonpartisan pro bono technologists that give direct support to governments and organizations responding to crisis. We've actually partnered on projects like COVID Exit Strategy and COVID Act Now. But I want to talk a little bit about the kind of second order effects of what's happening with COVID, and to reflect on what people have covered already, just what does it look like inside the government teams that are actually trying to operationalize these new benefits or respond to COVID from the inside. So next slide. So I'll cover three main areas, basically, and go in that order. Next slide. So when it comes to unemployment, you can do the next slide too, actually. We're seeing record levels of unemployment in the US. In April, the US reached a record high, 14.7%, highest since the Great Depression. But what's not being talked about as much is just the sheer operational load that's being placed on states to keep up. As you can see, as of June 30th, nearly half, about 19 million claims, remained rejected or stuck in backlogs. And 70% of that backlog for unemployment actually results from identity matching problems. It takes an average of 20 minutes of work to verify every single applicant's identity. And at that rate, it could take months to clear this backlog and get benefits to the people who need it. This is happening for a number of reasons, but the most important reason is there's just not a good way for states to identify whether people are eligible for benefits. And this process has been further complicated by, in a good way, the new programs that have been announced through the CARES Act and presidential memorandums, but that's adding 5 new types of unemployment insurance programs purely for COVID-19, further complicating the jobs of these claim managers. Next slide. Something we've been working on is figuring out a way to give better technology and tools, especially using things like off-the-shelf or industry-leading identity verification tools to help these claim managers move faster through the backlog and get benefits to the people who need them. In the end, I think the recommendations here are states really need to focus on automation on these manual processes, and there are many different ways that work is happening now to support them. Next, we'll talk about elections, and actually I'll let Robin share a bit about our work here.
Great, thanks very much. You can go to the next slide. There are 4 primary areas that we've really seen the highest technical need on the part of election officials. This is, I will say, outside of the critical infrastructure like voter registration databases and reporting systems that need to be very sort of hardened to outside activity. The first is around improving information and communications that give voters access that they need. And that's online resources. One of the things you have in front of you here is a website template that we've created with some partners in the elections NGO space and has been adopted by probably at this point maybe a dozen communities around the country. Another area that we've seen a lot is in automating processing. So for example, this giant increase in vote by mail interest means a giant increase in logistics and processing of pieces of paper, both getting them out, tracking them, getting them back, and handling those. In the past, when vote by mail was a small percentage of what people did, it wasn't a big deal. You could manage it with spreadsheets, but now when it's gone up exponentially, it needs more automation to be able to get done. Third area is around managing poll workers. As you all probably know, most poll workers in the past have been retirees. Folks, average age in the country was 72. Those are folks that are at higher risk for COVID. So lots of places are getting new poll workers, which means more training. And so managing that whole process has been something we've helped a lot with. And then clarifying election results. Again, this has been the change in how people want to vote because of COVID means a change in how soon we're going to get results. And so helping the election officials communicate about that clearly on election night is going to be important. Obviously, this matters a lot because the trust in the system is foundational to trust in the results. And so we are doing all we can to help the local election officials who are doing yeoman's work day and night to get this right and need all the support they can get. Raylene, you want to talk a little bit about healthcare?
So just to kind of reflect back, I think a lot of what we're doing is supporting government public health officials on the inside. So if we show the next slide, a lot of what we're doing is actually helping build these more internal facing dashboards. I think right now states are facing kind of an unprecedented scale of the pandemic. It's really overwhelming the internal tools and systems that they have in place and their ability to reconcile different data sources like hospital ICU bed capacity with positivity rates and case trends. So something that we've tried to help with is improving that internal data infrastructure within governments and helping them scale their testing and tracing programs and kind of tying these disparate data sets together. I would say the biggest thing is these dashboards are hugely powerful for counties that are really trying to understand and make decisions. And in a lot of cases, big improvements can be made with relatively small changes and introduction of new tools. So that's something we're excited to see as more counties are improving their internal dashboards. Thanks. Yeah, that's it.
Awesome. Thank you, Raylene. And to wrap up, I'm going to talk quickly about the state of federal data and data sharing. So for us here at COVID Exit Strategy, we do our best to aggregate publicly available data sources, and most of our sources come from the state level that's being aggregated by the COVID tracking project. And so with that comes some issues, right? You have cases where I think there was a question that came in from the AP around why is, I think it's Mississippi at 100% positivity as well as Puerto Rico. In states like Mississippi and in a place like Puerto Rico, the way they report is inconsistent to the public, but the way they report to the federal government actually is quite clean and clear. And so the data that the federal government has is one that we here have been very persistent about trying to advocate to be released. I think folks remember back in July, the first task force report was shared in its full form. A week later, the New York Times did the same thing and found another copy of the report. And then very quickly after that, the report distribution got locked down. And so it's been quite some time since a full report has been leaked. But thankfully, the select subcommittee went and asked the task force, hey, can you give us copies of those reports? And so if you go to their site, you can actually find a link to 8 reports from the period of time of June 23rd to August 9th. But of course, the pandemic is still happening and these reports were continually being produced. And so a few weeks later, on September 16th, the committee asked the task force, hey, you continue to put these reports out. they're important in keeping Americans safe, you should really make them public. And so there was a deadline set a few weeks ago now, September 23rd, for all the reports to be shared, as well as an ask that within 3 days of sharing with the governors, that they be shared with the public as well. And unfortunately, that still hasn't happened. And so what's happening today is that the task force shares these 50 reports to all the governors, and it's up to the governors to decide if they want to share it or not. Liz Whiteley from the Center of Public Integrity continues to aggregate these reports. Most of them, most being the 13 that are states that are willing to share, either come from the states themselves sharing or still continual leaks. And this is still an incredibly important issue to tackle, because this piece of research from Pew came out that says, for folks that rely on the administration as well as the task force for coronavirus news, they come away saying that the outbreak has been controlled, or we've done everything that we can or could. And the reality is we still haven't. And so if you look at one of the most recent reports that was leaked, this is the October 11th one, the reports, by the way, continue to get better and better. So all of my comments towards the teams that produce it, they're doing incredible work, but unfortunately the public's not getting access to them. They added a national picture now to it. So there's a few more slides, a few more pieces of information, and you can clearly see things aren't going well. The colors of all the states look like the colors of all the states on our map. They have a picture of positivity as well too that shows the full spectrum of how things are going in each state. And so to the question from the AP, there's data that helps give us an actual true view of what that positivity is. We don't have it because it's not being reported at the state level, but it certainly is being reported at the federal level. And so it's incredibly important for us to continue, at least on our part and all of us, to keep pounding on the door to say, this is a national crisis. A national crisis requires a coordinated response, and a coordinated response requires public data. And so with that, we're going to start opening up for questions. So if you have questions, please drop them into the chat, and as well as use the raise your hand function. And for folks, you can turn on your videos again for the panelists so we can start to pass these questions around. And Liz is actually on this panel, on this chat as well too. And so she just dropped a link into the chat showing you all of these reports, of these task force reports. So from Will Stone from NPR, can you talk about how the coronavirus outbreak is playing out in the Midwest, Great Plains? Are the communities seeing the most spread rural and suburban more than cities, or is it both?
I can just share some information about this. Well, as we know, in states in the US, there's a huge discrepancy between urban and rural just at the state level. States like California have less than 10% of the population in rural areas. States like Maine, over 50%. So as we look at the states in the Midwest, a number of them are on the higher end of the percentage of the population that's rural. So when we hear a state like North Dakota, South Dakota, Montana having COVID, undoubtedly it's going to be hitting rural communities. Just to share, if I can really quickly, this is a look at counties in the U.S. and urban-rural classification, and you see the green essentially are more rural areas, so across the Midwest, right? And then if you look at where COVID positivity rates by county, and this is from the Children's Hospital of Philadelphia data that we're looking to get, you see most of the red again in these areas where there's a lot of the population in rural areas. So I would say, that what optimally I would go to the state websites or the county websites to look exactly at the details. But even here on the county level, you get the sense that a lot of the red here is in the same areas where there's a lot of rural communities.
Thank you, Cyrus. Marta, anything else to add, or next question? Perfect. The second question comes from Emma Court at Bloomberg. There's a lot of political conversation now about herd immunity. Do you see that thesis gaining political influence? How does it compare with what the US is doing now to fight COVID-19? And what do you think of it in terms of being a viable strategy for the pandemic?
I can comment first. I think herd immunity is essentially what's been proposed, either the Great Barrington Declaration or others that have talked about it. It's basically looking for a quick fix or an easy way out of what we're experiencing. It's not only not helpful, it's mixed messaging that'll lead to preventable COVID-19 cases and deaths. We don't know what level of immunity is needed, but we know we're not close. 6 out of every 7 Americans have not had COVID. So to get to that level of 20, 30%, even the lower end of estimates of herd immunity, the path there is hundreds of thousands of American lives, just to be clear. So that's not really a strategy that is based on science. It's kind of a default. And yes, we are kind of seeing rising prevalence or rising number of people who've ever been infected. But to pursue it as a strategy, I think is immoral. To say that we let young people get infected, doesn't acknowledge that young people are increasingly around older people. They live at home, they're connected. We can't isolate younger people, even though they might have less severe disease, and not expect the virus to hit older populations. And when it does, we're going to see more severe outcomes, including deaths. So I think in terms of our perspective at Resolve, we strongly oppose this idea of herd immunity as a strategy for the reasons that I mentioned.
Thanks, Iris. If there's more follow-up questions on that piece, feel free to drop them into the chat. We've got another question from Annette Newell. Morning, Annette Newell from KXL in Portland, Oregon. Can you comment on this conclusion you've released in your press release this morning? This is troubling in states like Florida, Nevada, and Oregon, where the number of tests have been low and flat over the past 2 weeks. And that piece there is regarding, I can share my screen and show you exactly what that means. So what ends up happening is that positivity rates go up and down. And Cyrus, please, you've been the one that's educated me on this. And so the part that was made in the press release was, you've got a set of states that, I'll pull them up, Florida, Nevada, and Oregon, where testing is flat, but positivity is increasing. And what does that mean?
It means that, it could mean a couple of things. One is that they're prioritizing testing more. So they're testing high risk, those likely to test positive. If they're using 100 tests, for example, the 100 tests are being used on people who are more likely to test positive. So basically, essentially, for example, people who are symptomatic, they have a higher likelihood. If you test 100 symptomatic people or people who work in healthcare settings, for example, they might have more of those be positive than if you test just 100 people who are, in the community or staying at home, right? So less of those would test positive. So they have a higher risk of disease. But I think as their positivity is going up, it could also reflect that, there's more people in the community with the disease, right? That's the concern. That if I use the 100 and out of the 100, 5 test positive, and then the next week it's 10, and then the next week it's 20, well, that indicates that, if I'm using the same testing strategy, more people are turning up, I'm detecting more people, that means we might have a growing problem with COVID. So there's a few things that can affect that, the positivity going up in the setting of stable testing.
That's why in our world, we always show, the cases per million, the positivity rate, as well as how many tests are being done, because a state could decide to test less, and that's going to create a lower case number per million or 100,000, whichever metric you follow, but the positivity rate will still go up. And so a state could celebrate, hey, we have less cases, but if positivity is increasing, it means you're just sort of turning an eye towards the problem. And so you can actually see, if you sort by the percent of tests adjusted, really where each state is at how much they should be testing. And so there's a handful of states that are testing really well. And the way that this number and this metric works is, at the start of this crisis, we really relied on this 500,000 per day number as a baseline. This came out of the Rockefeller Group. But as that number was met, what's the real target to go after? And Cyrus had a really great explanation a few calls ago around this incident adjusted target. Like, you should be testing enough to get your positivity rate to 3%. And if that's the case, how many tests should you be running a day? And so you can see that as your positivity rate goes up, there's going to be a really big demand for tests. But the reality is that goes down as you start to test more. I hope that answers the question, Annette. If it doesn't, feel free to put a follow-up in the chat. There's a question from Daniel Goldberg. What do we know about hospital capacity and hotspots? We're seeing real issues in Utah County, in part of South Dakota, and in Oklahoma City. What do the next couple of weeks look like around the country in terms of hospital and ICU capacity? Marta, do you want to?
Yeah, Ryan, could you pull up the hospitalization data? So it's very challenging to actually get data on anything less than state level. So the data that we pull on ICU percentage occupied and beds occupied comes from HHS, from HHS Protect. They collect these data from hospitals. The data have been not extremely reliable, but this is the best we have. There is really no information that we are aware of that you could actually go on a much more detailed level in a way that you're speaking about. So basically on a county level. So, but something that something that I wanted to flag for you moving forward. Maybe this is not about the next 2 weeks, but it could be in the next couple of months. Something to keep in mind is that now a couple of companies have asked for an emergency use authorization for monoclonal antibodies. And these products are infusion products, outpatient infusion products that can also be for inpatients that are likely to be indicated for patients with mild and moderate COVID. And there's lack of clarity yet about how those could be, how they could go to the patients that need it. For one, there's going to be shortages of this just because of the sheer number of patients that could qualify with mild and moderate disease. But setting that aside, the delivery is going to also be challenging because those are infusion products. This is not a vaccine that you come in and quickly you leave. In clinical trials, for some of them, you actually they were being infused for an hour. So the question is, do you take it to infusion centers where patients where there you have already immunocompromised patients? Another alternative is to actually take them to the ER. Just think about the number of patients that might be coming to the ER to see if they can get a monoclonal antibody. So I wanted to put this on your radar screen. This is still something that folks are thinking hard about, or I'm hoping they're thinking hard about, because this will really be a major challenge depending on what channel we go through. And there's going to be questions around how to prioritize these drugs and get them to the patients who could benefit the most. And it might have an impact on if ERs are being used for this. This could have incredible impact on the ER capacity. So something to watch for.
Thanks, Marta. From Gabby, given the White House's recent emphasis on rapid antigen tests, what do we know about if and how these test results are being reported in the States? Marta, do you want to take that one because we've had a lot of conversations around what's being reported, our work with COVID tracking?
It's a good question. We don't know how it's reported by different states, or rather a number of states consider. So with an antigen test, you don't have the kind of clarity as you have with a PCR test. So they should be considered presumed positive, and they should be verified with a PCR test. And so some states choose to not report them as positive. They don't report them because they're presumed positive. And there's basically variation across states in how the reporting happens. So we don't have sort of a common benchmark for that. Another piece and so we don't really have a good sense, not only for how many positive cases there are, but how many of them are being administered. It will have potentially implications for the positivity rate. I would encourage you to actually listen to our last press call where Cyrus actually walked through this in much more detail, but we do have concerns about what positivity, how meaningful positivity rate might be going forward if antigen tests really ramp up.
And the piece that I pulled up while Marta was speaking is from the COVID tracking project that they published this past week on dissecting how different states are counting positivity, whether it's people versus specimen versus encounters, what makes each one better, but also, they provide examples of like how, depending on which method, a state like, in this case here, Missouri can be everything from 10% positivity rate to 17%, right? When you're looking at tests, the actual ones that are being done, sometimes people get tested twice, there's lots there. And so just even on the viral front, there's still a lot to unpack. And so our hope is that more states report exactly what's inside that number. And Marta, one more point there too. It's not even just like what kinds of tests, but aren't there some states that also, for groups that are congregated together, they just report as one? Is that related issue here?
Yes, we did hear that West Virginia, there have been reports. So we have, this is really through media reports that West Virginia counts in a congregate setting, they count all the cases as one case. And so clearly this is going to affect your positivity rate. Again, this is really secondhand, not firsthand, but things like that obviously have a tremendous impact on what positivity rates you have.
Another question that comes in, I think this is for you, Andrew. Is there any hope for a COVID relief from the federal government deal before the election, or are we looking post-election, or others as well too can answer? But
my gut reaction to answer that at 12:19 p.m. Eastern Standard Time on October 14th, 2020 is we're looking at after the election, but in the next 5 minutes that could change. There's really no way to know that. The dynamic that we have been in for at least 2 or 3 weeks now is that the president seems to want a deal because he thinks that it will help bolster his reelection prospects. He has tapped Treasury Secretary Mnuchin to deliver that deal for him in negotiations with the Speaker. The Speaker has been incentivized by the Republicans in the Senate not to come to an agreement very quickly, because the Republicans in the Senate want a far smaller deal than the president is advocating for and that the Speaker is advocating for. And so there is a disconnect between Senate Republicans who are trying to confirm a Supreme Court justice at the moment and their own president of the same party. Speaker Pelosi, who is very adept at getting her members swimming in the same direction, has so far been able to withstand pressure from more moderate members of the House of Representatives that are pushing her to take a deal from Mnuchin and the president, which even if she did, which she has given every indication that she is not going to do that, even if she did, that still seems to have trouble getting through the Republican Senate, where for the first time in the Trump presidency, Republican senators are bucking the president of their own party.
thanks, Andrew. We've got one more question, and I just put in the chat. If there's any left, feel free to drop them in. If not, we likely will wrap after this one. I think this is targeted to both you, Raylene, and Robin, on the unemployment insurance front. What's happening on the ground there today with the states that you're working with? Are those systems overwhelmed? What are you seeing? Are there any other stories or vignettes that you have?
Robin, feel free to jump in as well. Yes, I think there's a lot happening. I think it varies quite greatly state to state. The way that we're structured as each state is kind of operating and managing their own systems. I think, let's see, Robin, do you have any specific anecdotes that are worth sharing on states?
Well, there was obviously a huge spike in claims back in March, and it's tapered off, but it's still tapered off at a level that's exponentially larger than we've seen in past years. So it's still several, millions of people doing these applications. So what we haven't seen is a fall. It's certainly not back to normal. And so what that means is, particularly for the backlog of claims, that states are still scrambling to keep up. So the problem, of course, is that these systems have been optimized over the past to sort of weed out people that are cheating and not weed out fraud. And so what we've seen are these big criminal fraud activities that have bilked some states out of, $500 million in unemployment benefits, and also then kept people who legitimately deserve them from getting them. So states are just working through that. And while there's progress, it's slow. But really, this is going to be a long-term effort to try to change the way we provide these benefits to folks and deal with real threats.
I guess one thing to add to on Andrew's previous point about the relief packages, I do think states have gotten a handle on the different types of unemployment insurance benefits that were introduced as part of the CARES Act. But one big challenge for states is if a future stimulus package introduces a new class of different types of benefits with different rules and income cutoffs, that's going to start a whole new process of every state having to figure this out. So I think that would be extremely challenging, actually.
Thanks, Raylene and Robin. We got two
I'd
more
also
questions.
like to just very quickly point out that the symbiotic relationship here is that unemployment in a country where 160 million of 300 plus million people get access to the healthcare system through their job. And so that's something that US of Care has been talking quite a bit. We put out a blog and a brief about 3 weeks ago about job-connected health insurance. And as I said earlier, the Employee Benefits Research Institute estimates that over 14 million people have lost health coverage at this time of a historic pandemic, when you really, really want people who might be sick to go see the doctor. And if they're not able to do that, that just compounds the problem. And so we are not calling for right now the dissolution of the job-connected health insurance paradigm, but we are certainly saying that it is something that we need to take this opportunity and this moment in history to look more deeply at, if that is the structure and paradigm that will best serve America in a crisis moment like this pandemic.
Thanks, Andrew. Question from Jacob Wentz. Florida House Speaker Olivia recently alleged the state is over-reporting death rates and advised representatives not to use this data to make policy decisions. How do we navigate an environment with complications surrounding data reporting and state leaders that don't trust their own government data? This is probably the most painful part, right? It's that I think the part here is just, I'm just going to share one screenshot, and it's from, the HHS Protect website, which proudly says they've got 200 different data sources that exist. And, if there are questions about the data at the state level, you should be able to turn to the federal government to be able to find and cross-check those things. One of the things that our site has been able to do is if there's an anomaly anywhere in our data, it usually means there's something wrong with the data pipeline, or there's an issue on the ground that needs to be fixed, whether it's in hospitals reporting. And so it's really, really just painful to see that there's all this rich data that's going to the national level, not being shared. So, in a place like Florida, you can at least then have two data sources to look at, right? What is the Florida data saying? What is the federal level data, saying too? I think the part that shows that it's possible to produce this data comes in places like this, where CMS put out some guidance for nursing homes, which they're responsible for, and in that guidance it says, if there's this certain positivity rate, you are supposed to do certain things, right? When the CDC did that same kind of guidance for schools, it kind of said to the public, hey, figure it out what positivity is within your communities. You've got to do that on your own. But CMS, clearly, because they're responsible for these places, actually released the data as well too. And this one is also another hat off to Liz and the team at the Center of Public Integrity, where they found that they were sharing HHS Protect data in a kind of corner of a website. And it's just one of these frustrating things that this issue, Jacob, that you highlight could be resolved so much easier as if everyone just shared all of the data that they have. This is a virus. It doesn't respect borders or boundaries. It's going to go everywhere. I think it's worth also sharing. You have states that want to know what's happening within their neighbors so they can produce good guidance, right? If you go to the state of Massachusetts travel website, which says if you're supposed to quarantine, what you're supposed to do, they point to our site, COVID Exit Strategy, because we aggregate that data together. We do it and we keep it up to date because it's a public service that we do, but really the federal government should be stepping in when folks are trying to figure out what they're trying to do when they're moving between states. And so I hope that answers that question, Jacob. Maggie Mullen has another question. As hospitalizations and active cases rise, the number of people reporting mental health issues like anxiety and depression are skyrocketing. Thoughts? What's to be done?
So I'm not a mental health expert, and I would recommend you speak with folks who have that expertise. What I would like to point out is that what probably is going on and will probably complicate things is that, one reason that the cases and hospitalizations are going up is because we're increasingly moving indoors. Moving indoors is our ability to socialize with folks is much more limited. That's part of the reason why we are seeing the rise in cases, but it also means that we should be socializing less in person. And that is we are social beings. And so this is going to be a challenge, and this is going to be a hard winter for all of us. So this is a really important question to be asking, basically. And so I recommend you talk to a lot of health experts, mental health experts. But Cyrus, you want to chime in?
I just want to say it's just sort of also a reminder that this pandemic is going to last years. I mean, it's not deaths or everybody else is okay. We have chronic physical conditions debilitating thousands of people around the country. We have mental health impacts on both those who've been affected, their families, healthcare providers taking care of people who are sick. All of these groups have been impacted in ways that don't necessarily lead to death, but lead to really, a lot of debilitating impacts. And so this is something that as a country and as a world, we're going to have to deal with for years to come. But it's a reminder that it's just not all about, that if cases are high and deaths are low, it doesn't mean everything's okay.
Thanks, Cyrus. I want to thank everyone for joining, especially my colleagues on the call, and for everyone for their questions. We will probably do one of these in a few weeks. I think 2 weeks, actually, probably the week of the I'm looking at the calendar, 26th, because it's a lot is changing very quickly. And so if you have any questions between now and then, feel free to send them to press@covidexitstrategy.org or reach out to any one of us. You likely have our email addresses by now. Have a wonderful rest of the day. Take care, everyone.